Dr. David Blancho. I practice podiatry in Southwest Missouri, Southeast Kansas, and the surrounding areas. All right, today we're going to be discussing posterior fibular plate. This plate consists of a 6-hole and a 9-hole option. These plates are left and right specific and will be indicated for fixing the fibula where there is a fracture that you would like to address. So this technique is often used when we are addressing the fibula from a posterior aspect. It can also be used when we're addressing the posterior mal to get access to both of those fracture patterns. So when we make our incision, we're going to find the posterior border of the fibula right here, the lateral border of the Achilles tendon. We're going to make an incision right in between the two. This incision length is dependent on getting access to not only the fibular fracture, but also if there is a posterior malleolar fracture, your incision will usually need to be a little longer than anticipated. As we dissect through the soft tissues, the primary thing we're looking for is the sural nerve, and identifying it and retracting it out of the way. Once we've identified our sural nerve, we can then deepen through the posterior corridor, and if there is a posterior malleolar fracture that we're going for, you have the choice to fix it first or to fix the fibula. I typically fix my posterior malleolar fractures first. We'll dissect through the posterior lateral corridor, we'll identify the flexor hallucis longus tendon, and we'll fix the posterior malleolar fracture if indicated. Next, once the posterior malleolar fracture is fixed, we'll then identify the peroneal tendons and the peroneal musculature. That will be carefully dissected off the posterior border of the fibula. We have the option to retract them medially or laterally. So typically I retract the peroneal muscles and peroneal tendons laterally to gain access to the fibular fracture site. Care is taken to maintain the peroneal retinaculum at the inferior aspect of the incision, as well as also care to maintain the sural nerve. Once the fracture is appropriately reduced, we'll line up our plate on the posterior border of the fibula. This plate fits very well in the distal aspect of the fibula and contours with the curvature of the distal portion. Next, I will temporarily fixate the plate with olive wires, but can also be done with K-wires. Next, we'll take fluoroscopic views to ensure there's anatomic position of the plate as well as the fracture is appropriately reduced. You will have the option of using 2.7 millimeter, 3.5 millimeter, and 4 millimeter screws with this plate. There are locking screws and non-locking available. All the holes in the posterior fibular plate have a 60-degree cone of angulation and can be locking in 30 degrees in any direction. At this point, we have the option to fixate with an interfragmentary screw that can be placed through the fracture site at an angle to where it is perpendicular to the fracture. If we have good temporary fixation, we can also just begin fixing proximally to the fracture site. I will typically go 1 hole above the fracture and place a non-locking screw that will allow for the plate to compress down onto the bone. You'll notice that the dual lead screws will advance quickly and create good purchase in the bone. Once the plate is secured with the screw, I will typically remove my distal fixation. I will typically take fluoroscopic views at this point to ensure that there is anatomic reduction of the fracture site and good apposition of the plate to the bone. Next, I will fixate distally with locking screws. Typically these screws are unicortical in the distal aspect of the plate, and the further proximal in the plate we will use bicortical screw fixation. Lastly, I will remove my proximal temporary fixation olive wire and fixate with locking screws proximally. Lastly, I will fill the screws as desired for the strength of construct needed. You will also notice there's a significantly low profile at the screw to plate interface, as well as a low profile at the distal aspect of the plate to minimize perineal irritation, as well as to decrease hardware palpability to the lateral aspect of the fibula. This will allow for the patient to still be able to wear most shoe wear without irritation in that area. Next, these soft tissues will then be closed in a sequential fashion as desired by the surgeon.